Hello, everyone, and welcome to your Chapter 26, Part 2 of your PowerPoint. We are going to start on slides, I believe it's 26. Yes, 26. My numbering's off because I added a title slide here, but we're starting on slide 26, and we'll continue through slide 53, I believe is our last slide. So let's go ahead and get started. We're first going to discuss the formation of dilute or concentrated urine. Up till now, we have been discussing healthy urine that is of normal concentration, but let's start off with our dilute urine. So the way we're going to establish our dilute or concentrated urine is by establishing our medullary osmotic gradient. So we're looking at the gradient out here in the medulla, of course. The osmolality that is set here, and you can see that on the right side of this image here. Without this gradient, we wouldn't be able to raise our urine concentration over 300 milliosmoles, which is what we're starting off with in the cortex over here. As you can see, when we move into our medulla, we start to see a rise in that osmolality in the nephron. So we said we are going to talk about dilute urine first, and that can be caused by overhydration. We get a large amount of volume of our urine, and it is dilute, meaning we have lowered osmolality of our urine. So in this case, we have either ADH not present or severely decreased, and the osmolality of our urine output is going to be at 100 versus 300, which is our normal amount. What's happening here is our ascending limb is going to decrease its osmolality, and that creates more dilute urine. We are not reabsorbing our water at that point, and our osmolality at the end could be somewhere around 65 milliosmoles, and that's going to happen when we have aldosterone present, which, if you remember, is going to reabsorb sodium and water. But in this case, since we don't have ADH or have decreased amount of ADH, our additional ions can be removed, and that causes the water to stay in our tube, in our nephron, and dilutes our urine. Now for dehydration, the opposite here, we are going to produce a small amount of urine and it will be very concentrated. So now we have a greater amount of ADH concentration in our urine, and osmolality is going to be about 1200 milliosmoles. And in this case, we use more of our juxtamedullary nephrons, and we have a couple different factors that are going to assist us in making concentrated urine. We have that facultative water reabsorption taking place, where ADH is going to add aquaporins into our DCT and collecting tubule, which is going to cause us to reabsorb more water. We also have to take into account that countercurrent multiplier, and our osmotic gradient is going to be created for our water to be reabsorbed once again in our DCT and collecting duct. We're also going to talk about urea recycling in the next couple slides, and urea will become reabsorbed back into our blood. And you would think, why would we do that? Because urea is a waste product, but it helps us in causing water to be reabsorbed. It changes the concentration so that water wants to follow urea. So more on that a little bit later. And note that we are going to be using our vasa recta blood capillary, since we are using our juxtamedullary nephrons, where countercurrent exchange will be important. And we exchange nutrients and waste products with the vasa recta and still keep our osmotic gradient. So now we're going to talk about urea recycling. That's going to really help create our medullary gradient. And so urea is going to enter our filtrate in our ascending thin limb. So let me take you through this process real quick. We have urea that is 50% of it is reabsorbed here in the proximal convoluted tubule. So we only have 50% left here. And we're moving through, and we're going to see that later on. We are going to reabsorb some of our urea, and that's how we're getting a 100% here. We move past through the distal convoluted tubule here. 30% is going to be reabsorbed back into our blood. And so we're left with 70% here. But as we're moving down, like we saw before, we're reabsorbing 55% over here into our loop of Henle. So let's go back to our text here. Our urea enters our filtrate in the ascending thin limb of our nephron by facilitated diffusion. So again, we want our urea to stay in our nephron because it is a waste product, but we also reabsorb some of our urea because we want water to follow it in the circumstance of having concentrated urine, that is. Our cortical collecting duct is going to reabsorb water, leaving urea behind. And in the deep medullary region, now highly concentrated urea is going to leave the collecting duct and enter the interstitial fluid of our medulla. So out in this fun range over here of that high osmolality within our medulla. And our urea then is going to move back into the ascending limb, as we saw earlier, and contributes to the high osmolality in the medulla. So now we're going to talk about diuretics, and all of us consume diuretics at one point within our lives. These are going to be chemicals that are going to enhance our urinary output, aka making you use the bathroom more. So what this does is it inhibits ADH. So it's going to stop the reabsorption of water. ADH, once again we'll mention, is going to place aquaporins within your DCT and CT, and that causes the ability to move water out of those tubules and into our blood. So if we don't have ADH, we are not able to reabsorb that water. So alcohol is a big example of a diuretic in which this is going to happen. And sodium reabsorption inhibitors are going to assist with this as well. So examples are caffeine or certain drugs for hypertension or edema. We also have loop diuretics that are going to inhibit our medullary gradient formation, which will take a shift and cause us to increase our urine output. And osmotic diuretics, which are substances that aren't reabsorbed so that water remains within our urine. Now we'll do some clinical evaluations of the kidney. First we have urinalysis. And our urine, just a sample of urine is put into a cup, so I'm sure you've done this before in the doctor's office. And they use a little strip to test your urine to check for either use of illegal substances like a drug test, or we can check for other things like, is the specific gravity of our urine correct? Are there proteins within your urine? Is there blood in your urine? Or do you have high levels of glucose in your urine? And so forth. So it's a pretty simple test. You put the strip in and then you match the colors against the set that they have on the bottle for the strips. In order to assess renal function, though, we need both blood and urine for that examination. So we could do something like a renal clearance, which is going to measure the volume of plasma kidneys can clear of a particular substance in a given time. So really, we're just saying that this is the ability of our kidneys to remove molecules from our blood plasma and put it into our urine. So we want our unwanted ions to be cleared from our blood, and we're checking that with this renal clearance test. And what they're really used for are to determine the GFR. So we can use this to help detect glomerular damage or follow progress of renal disease. If we have reabsorption taking place, this is decreasing our renal clearance. If we're having a lot of secretion taking place, this is increasing our renal clearance. And I have this image of glucose and inulin over here because these are different types of substances that we can kind of check in renal clearance. And with our glucose, we want 100% of that glucose to be reabsorbed back into our blood. With inulin, what that is, it's a plant polysaccharide, and that one should not be reabsorbed nor secreted. So that brings us to our urine and the composition, or the chemical composition of it. 95% of it is water, and the other 5% will be solutes. And of course, we want our waste products to end up in our urine to excrete it from our body. So that's going to include urea, which we mentioned earlier, and that's going to be a form of amino acids that is broken down. So you can see in this nice little schematic here, we have our amino acid serine that breaks down into ammonia, which breaks down into urea. And if you let this urea stand long enough, it reverts back to ammonia. So I have a little dog, and we don't take him outside all the time to use the bathroom. We have a little pad in our laundry room, and I think it's called the potty patch. But if you leave that urine there long enough, you will get that ammonia smell that creeps back up. So interesting to know the chemical composition of this, how it reverts back and forth. The other nitrogenous waste we have is uric acid, and that is going to be a breakdown from DNA and RNA into nucleotides, then into nucleosides, into your bases, and the last we get is uric acid. And then we have creatinine, which should ring a bell from our muscular system lecture. This is going to be a metabolite of our creatine phosphate. So here's our creatine phosphate. We broke off that phosphate and got our creatinine, and we want to put that in our tubules to excrete. So what our solutes are within our urine is sodium, potassium, phosphate ions and sulfate ions, calcium, magnesium, and our bicarbonate ion. We can have an abnormally high concentration in any constituent within our urine, or abnormal components like we mentioned earlier in the urinalysis, where we have blood showing up, proteins, white blood cells, bile pigments, where we know we have some type of pathology happening within our body. So I really like this image because it goes through the rainbow of colors that your urine can be or possibly not be. So I'll let you kind of look at this on your own, but what we do want is to have a pale straw color, which is a healthy color of urine. So hopefully you are somewhere right within this range most of the time. We want to avoid going down into this brown area where you will be severely dehydrated or possibly have liver disease, or even right above that at orange. So this is a table I took from another anatomy text. I just thought it was a good overview of substances that may be found abnormal within urine and what condition it is from. So this is something to look over, to keep in the back of your head for your future nursing classes. I won't be testing you on this material though for your exam. So as far as physical characteristics, we already talked about color a little bit and said that we want more of that straw yellow color to show us that our kidneys are functioning at a healthy level, or we are healthy in all other circumstances. If it is cloudy, it might be a sign that there's a urinary tract infection, or it could also be a little bit of a sign of dehydration. A pale to deep yellow from a pigment known as urochrome um, is another normal characteristic that we're going to see. So what urochrome is a pigment from hemoglobin breakdown, and that yellow color is going to deepen with increased concentration, which is why we kind of get like a orangey or very bright yellow when we have high concentration of solutes. Or you can think of if you take a multivitamin, sometimes you get more of that highlighter yellow type of urine. And if you have abnormal color like pink, brown, like in this image here, or smoky, it could be caused by certain foods or bile pigments, blood in your urine, or maybe it's from a drug that you're taking. Another physical characteristic is going to be odor. So urine should be slightly aromatic when it's fresh. And we mentioned it is going to develop an ammonia odor as it sits there. So what's happening is the bacteria is metabolizing urea. And we may be altered due to some drugs that you might be taking. It might even change your urine color to blue or green, something very strange. Or it might cause a more pungent smell. Certain vegetables that you eat, like asparagus, will change the scent, and disease may also alter smell. For instance, patients with diabetes may have an acetone smell to their urine. Next, we have pH, and we want our urine to be slightly acidic, about the pH of 6, although it can range from 4.5 to 8. So when we have a drop in pH, it might be due to an acidic diet, eating protein or whole wheat. And if we have an increase in pH, that might mean we have more of an alkaline diet, like vegetarian. It could be due to prolonged vomiting or urinary tract infections. And then we are going to talk about specific gravity here. So specific gravity is going to be a ratio of mass of a substance to mass of equal volume of water. And specific gravity of water is 1. So what does all that mean? When we are trying to get our ratio for specific gravity, it is the density of an object over the density of another object, almost in every case, the density of water. So what we're really measuring within urine is how much solute, the concentration of solutes that we have in urine. So we have our urine density over water density, and that gives us our specific gravity. So our specific gravity of urine can range from 1.001 to 1.035. And this is because urine is made up of water and solutes, and it can range depending on your water intake and other things like your diet and certain drugs that you might be taking as well. So if you have a specific gravity that is greater than that 1.035, that means you will have concentrated urine and you're probably suffering from dehydration or diarrhea or vomiting, or maybe all three. You never know. So let's move into the ureters. The ureters are going to be these slender tubes that are conveying urine from our kidneys to the urinary bladder. And these are starting over at the hilum, so they begin at level of L2. Remember that the kidneys are in the range of T12 to L5. So ureters start at L2 and they will move on down through the abdominal cavity and into the pelvic cavity here. And these are also going to be found more retroperitoneal. So if you remember from the cadaver lab, you would be able to follow this ureter, but then it goes posterior to the urinary bladder and enters at the base of the bladder through that posterior wall. And as our bladder pressure increases, these distal ends of the ureters are going to close. They actually have little valve flaps in here, and that prevents the backflow of the urine from the bladder into the ureters. Let's talk a little bit about the histology of our ureters. We're going to have 3 layers of our ureter wall, and I want you to be very careful that you don't mix up these layers with what we have going on in the digestive system. This is separate. This is urinary system, although it does follow a similar pattern. So if we're looking at the internal surface of our ureter, that is going to be called our mucosa here, and it consists of transitional epithelium. After that, we have our muscularis layer, and this is made up of smooth muscle, just as we're used to in the digestive system. And we are going to have a longitudinal layer as well as a circular layer. But these are a little bit switched. Remember, in our digestive system, circular layer was more internal, longitudinal was more external. And so what this muscular layer does for us is it's going to propel urine through this ureter into the bladder. And although we're going from the top to bottom, gravity is helping move that along, but we also have these muscles contracting and causing peristalsis, just how we had in the digestive system to move this urine down into the urinary bladder. And lastly, we have the adventitia, which is the outer fibrous connective tissue portion. Remember, in the digestive system, we mostly have serosa, which is also made up of connective tissue, and it helps to kind of support those organs. But within our urinary system, most of the time we have adventitia, which is connective tissue too, but now it's blending that connective tissue into the surrounding areas. Oh, got to the wrong slide here. There we go. So with our clinical prevalence, we have renal calculi. And these are going to be kidney stones in our renal pelvis. And we can see this well illustrated over here. This occurs because we have crystallization of calcium, magnesium, and uric acid salts. And these stones are going to block our ureter, causing urine to kind of move retrograde and put pressure on these microscopic nephrons back in here, which is going to cause pain and of course can develop into an infection. So the reason we get these stones could be due to a chronic bacterial infection, urine retention, increased calcium in our blood, which can be caused by an increase of that parathyroid hormone, or it could be due to increased pH of our urine, which we will touch a little bit more on in chapter 27. So the treatment for kidney stones is, if they're small enough, the doctor may just recommend that you let it pass. But if they're large enough, we can use shock wave lithotripsy. And this is non-invasive. It basically uses ultrasonic waves to pass over to the kidneys, and the vibrations of those ultrasonic or ultrasound waves are going to break up these stones so that they pass through a little bit easier. Next, we have the urinary bladder, and this is going to be a muscular sac for storage of urine temporarily until we move it through the urethra. So this structure is also retroperitoneal. We will find it all on the pelvic floor and posterior to that pubic symphysis, the most anterior part of the os coxa. And we're going to have a difference in this in males and females. In males, we're going to see that the prostate is inferior to the neck of the bladder. So here's our neck of the bladder. Here is our prostate. And within females, let me see if I have a picture of that on the next slide, but that's going to be anterior to the vagina and the uterus. So let's talk more about the bladder itself. We have openings to the ureters, which you can't see too well in this image, but I think I have a better one coming on up. And then we also have an opening to the urethra down in here. Oh, there it is. Sorry about that. I don't know why I was going all the way up here. Probably because I saw these guys coming in. So here are our openings to our ureters, okay? And our next opening was to the urethra. So that creates a nice little triangle for us, and we're going to call this zone the trigone. And this is kind of where urine is going to stream through the most frequently. This is also where infections tend to persist because this is where urine is going to sit the longest. So to talk about some histology of our urinary bladder, we have almost the same layers as our ureters here. So the innermost layer is going to be our mucosa, which will have transitional epithelial mucosa. And then we have our muscular layer further back in here, which is going to be made up of a very thick detrusor muscle. And this contains 3 layers of smooth muscle. We have inner and outer longitudinal layers with a middle circular layer. And lastly, we have adventitia once again. All over the bladder except for the very top part of the bladder, which will be covered by our peritoneum. Next, we have urine storage capacity. Just like our stomach, our bladder is going to kind of collapse when it is empty, and we are going to see these curvy mucosa layers in the internalmost aspect of the bladder, and that is called rugae. When our bladder is going to fill, it will expand and rise superiorly during filling without significant rise in internal pressure. A moderately full bladder is going to be about 12 centimeters long, or 5 inches, and can hold about 500 milliliters or 1 pint. We can hold twice that amount if necessary, but it can burst if it is distended. There was actually, back in the 16th century, a Danish astronomer, if I can speak, and I'm probably going to mess up how to pronounce his name, but his name was Tycho Brahe. And he was at a dinner party, and it is an insult to leave the banquet table before the meal is over. And he was an excessive drinker and had a bladder condition already, but he held his urine through that meal and his bladder burst. And so over the next 11 days, from his bladder bursting, he slowly and painfully died because of that. So always make sure to go to the bathroom. You never want to take a chance, although you probably will pee yourself before your bladder bursts. So this is a pyelogram over here, and this is going to be an X-ray exam that a doctor might suggest to take a view of the kidney, the ureters, and the bladder. They use a iodinated contrast and inject it into our veins so that you can evaluate the collecting systems, and you can see them pretty well in here. Some of the calculi, the renal pelvis, through the ureter and down into the urinary bladder. So this was typically used to diagnose if you suspect somebody has kidney stones or bladder stones or an enlarged prostate or kidney cysts. So moving down into the urethra, our last major organ of the urinary system. This is a muscular tube that is going to drain the urinary bladder. We have the lining epithelium here that's going to change quite a bit as we move through. So most of it is going to be pseudo-stratified columnar epithelium, which we see in this histology slide here, except for as we move closer to the bladder, we'll see more transitional epithelium. And then as we move near the external urethral orifice, which we'll talk about in a minute, we will see more stratified squamous epithelium. So here are those sphincters that we're going to discuss. We have the internal urethral sphincter. This is made up of smooth muscle, so we have involuntary control here. And what's interesting is this muscle actually contracts to open, which we are so used to sphincters being our circular muscles and contracting to close a tube or opening. So a little different here, it contracts to close. Now our other sphincter is the external urethral sphincter, and this is the one that's made out of skeletal muscle. So we have voluntary control over this, and this basically helps us from going to the bathroom as soon as our bladder fills up. So it's going to pass through our pelvic floor here. We do see some differences in the urethra in males and females. In our female urethra, which is not pictured here, it is going to be about 3 to 4 centimeters and tightly bound to the anterior vaginal wall. And our external urethral orifice is going to be anterior to the vaginal opening and posterior to the clitoris. So here's our image of the female urethra. You can see how much shorter this is compared to the male, which we previously saw. This would be the full length of the male over here. And we could see internal urethral sphincter here, external urethral sphincter, and the orifice here, and the sphincter over here. You can see that it lies a little bit more external to the actual urethra. All right, so let's talk about those different portions of the male urethra. What's interesting in the male is that it's going to carry semen and urine, although we'll talk more about the semen portion in Anatomy 3 when we get into the reproductive system. But our urethra has 3 different names in the male. We have the prostatic urethra, that's about 2.5 centimeters long, and it lies right within that prostate accessory gland of the male reproductive system. Then we have a short span here called the intermediate part of the urethra, also known as the membranous urethra, and that's about 2 centimeters long. And it passes through this area called the urogenital diaphragm that's made up of muscle. And it starts at the prostate, ends at the beginning of the penis, where we start to see that corpus spongiosum tissue. So from there on out, we call this the spongy urethra or the penile urethra, and it's about 15 centimeters long, passes through the penis and opens at the external urethral orifice, where we'll have that stratified squamous epithelium. So the last major topic we're going to talk about is micturition. This is also known as urination or voiding. And we have 3 simultaneous events that must occur. We have the contraction of our detrusor muscle. That was a part of our urinary bladder, and this is caused by our autonomic nervous system. Remember that our autonomic nervous system, this is really dealing with our motor neurons, and it's broken into our parasympathetic and sympathetic nervous systems. Our sympathetic nervous system is going to inhibit micturition, whereas parasympathetic will stimulate it. Next, we have opening of the internal urethral sphincter by our autonomic nervous system. And lastly, we have the opening of our external urethral sphincter by our somatic nervous system. So I have this image to the right here where I discuss a little bit more of the neuroanatomy that has to do with micturition. So this is going to be a little bit extra information for those of you that just can't get enough of anatomy. So if not, you can fast forward through this portion, although I don't know why you wouldn't want to know this information here. But this image here is going to show us the urine storage reflexes. So we get distension of our bladder, filling it up, and we're going to produce low-level vesicle afferent firing. So we're basically sending information over to our central nervous system saying, you know, our bladder is full. This is stimulating our sympathetic outflow in our hypogastric nerve over here, connecting um, to our bladder outlet, which is going to be the bladder base and the urethra. And it's also stimulating our pudendal output. So here's the pudendal nerve. Pudendal actually means embarrassed, and this is a nerve that supplies this pelvic region. So I don't know, anatomists thought this is an embarrassing topic to talk about, and they named this nerve pudendal. Anyway, this pudendal outflow is going to the external urethral sphincter. So, where was I going with this? What these two nerves are doing are promoting continence. So having self-control of our bladder. And we simultaneously are going to inhibit the contraction of the detrusor muscle that is within the urinary bladder, so we can hold our urine. Now this second image here is showing us our voiding reflexes. So when we are trying to eliminate our urine, we are going to get intense bladder afferent firing in the pelvic nerve that's going to, now stay with me here, it's going to activate our spinobulbospinal reflex pathways. And this is really showing us our pathways in blue here. This really has to do a lot with neuroanatomy. And that is passing through our pontine micturition center, and will stimulate our parasympathetic outflow to our bladder and urethral smooth muscle, which we can see in the green over here, the connection over to our urinary bladder. And this is inhibiting our sympathetic and pudendal outflow over here. There's our pudendal outflow. That's why we got the little negative signs there to inhibit that sympathetic outflow. Our ascending afferent input from our spinal cord might pass through our relay neurons in the PAG, which stands for periaqueductal gray, before it reaches the pontine micturition center as well. So again, this is all extra information. I won't be testing you on this. What I will be testing you on is this micturition reflex that happens. I just want you to have a general understanding of what's taking place here. So let's start over inside the bladder. Once it is filling and distending the bladder wall, we start to get action potentials sent through stretch receptors here in our bladder, sent along pelvic nerves to our sacral region of our spinal cord. At that point, we are going to have our parasympathetic nerves contract our smooth muscles in our urinary bladder. We also send signals through our ascending pathways that's going to tell our brain, hey, you have to go to the bathroom, your bladder is full. So we're making connections here in the pons, in that pontine micturition center, and also sending it over to our cerebral cortex, where we have conscious thought taking place, telling us to go to the bathroom so that we can urinate. Then we send information or action potentials through our descending pathways all the way down to our sacral region once again. And that is going to send information out through our somatic motor fibers, lost my mouse here, over to our external urethral sphincter, telling it to relax and allow the urine to move out of our body. So this is our reflexive urination that's going to take place in infants. So they don't really have that conscious control just yet, but they get a distension of the urinary bladder. We get stretch receptors that are activated. This causes our parasympathetic nervous system to be stimulated, and our sensor signals into our sacral region. So here we are moving down from our pontine micturition center. We're moving on down into the sacral region and sending information through our parasympathetic nerves over to the bladder. This causes the detrusor muscle to contract, and that causes our internal urethral sphincter to open, the external urethral sphincter to open, and urine moves on out. So we don't have that ability to have our somatic efferents or our sympathetic nervous system to cause our external urethral sphincter to contract and hold that urine in just yet. At about the ages between 2 and 3, sometimes earlier, sometimes later, our pontine control centers begin to mature. And we have two major sections within our pons. We have our pontine storage center that's going to inhibit micturition, and our pontine micturition center that is going to promote micturition. So let's start with the pontine storage center. What we're doing is inhibiting our parasympathetic pathways and exciting our sympathetic and somatic efferent pathways. So that is allowing us to hold that urine in. But when we are ready to go to the bathroom, we can trigger our pontine micturition center and excite our parasympathetic pathways and inhibit the sympathetic or somatic efferent pathways. And this is a nice little chart that sums all of this together. We have our urinary bladder fills with urine, stretching those walls. The stretch receptors send afferent or sensory impulses to our brain. Our higher brain centers are then going to choose pontine micturition center or pontine storage center. So let's say we begin with the pontine storage center. We're going to inhibit micturition by acting on all three of our spinal efferents. So decreasing parasympathetic activity, increasing sympathetic activity, and increasing somatic motor nerve activity. Now when we're ready to go to the bathroom, we trigger our pontine micturition center. This is going to act on spinal efferents, so we are going to decrease somatic motor nerve activity that causes external urethral sphincter to open and micturition to take place. We are also going to decrease sympathetic activity and increase parasympathetic activity, and that causes the detrusor muscle to contract and the internal urethral sphincter to open, allowing us to micturate. Of course, if your internal one doesn't open, external one opening is not going to help you too much. So these have to go hand in hand. And that is going to be it for the last part of chapter 26. If you have any questions, please feel free to contact me at any time. I will be announcing when I will do a virtual tutoring session for any questions that you might have as well. On Blackboard, I'll announce it.